Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details whenever necessary. For the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the adrenal hyperactivity. The adrenal glands lie on the upper pole of the kidneys. Each gland consists of an inner medulla secreting adrenaline and noradrenaline and an outer cortex formed of three layers. From outwards they are zona glomerulosa, fasciculata and reticularis. Three groups of hormones are identified according to the metabolic activity as a whole, but 40 steroid compounds have been extracted. Principal hormones are cortisol, corticosterone, aldosterone, androstenedione, dehydroepiandrosterone, adrenocorticotropic hormone A.C.T.H. is the substance influencing the secretion of cortex. Hyperfunction of adrenal gland, Cushing's syndrome. It is defined as the symptoms associated with prolonged exposure to the elevated plasma corticosteroid levels. It is divided into two groups. A.C.T.H. dependent causes, iatrogenic, due to the administration of excessive quantities of A.C.T.H. or its synthetic analogs. Cushing's syndrome, pituitary dependent bilateral hyperplasia, ectopic A.C.T.H. syndrome, secretion of A.C.T.H. by malignant or benign tumors of non-endocrine origin. Non-A.C.T.H. dependent causes, iatrogenic, due to the administration of above physiological dose of corticosteroids, adenoma or carcinoma of adrenal cortex. Clinical features, moon face, central obesity, buffalo hump, accumulation of fat on the lower part of the back of the neck, plethora and hypertension, which is associated with the redistribution of body fat, sodium and fluid retention, muscle weakness due to the loss of potassium. Hirsutism, acne and temporal recession of scalp hair in females due to overproduction of adrenal androgens. Amenorrhea and other menstrual disorders are common. Psychological symptoms like depression may be prominent. Bilateral visual effects, expansion of pituitary fossa and pressure on the optic chiasma may occur due to an adenoma following treatment by bilateral adrenalectomy and replacement doses of steroids. Nelson's syndrome, brown pigmentation of the skin due to the high levels of A.C.T.H. in the serum together with secretion of melanocyte stimulating hormones MSH. A proportion of patients develop diabetes with adrenal glucose tolerance curves. Reduction in muscle, skeletal and connective tissue leading to weakness, proximal myopathy, osteoporosis. It is extensive, may cause backache, kyphosis, collapse and shortening of backbone. Easy bruising, purple striae on the skin of abdomen, thighs and buttocks. In case of adrenocortical tumor, symptoms depend upon the steroid. The gland is synthesizing glucocorticoids, cause Cushing's disease. Adrenogens, females virilized, pronounced hirsutism, deep voice, recession of hair on forehead, acne, clitoral enlargement, and increased libido. Males. Feminization in case of predominant estrogen. Though these are benign, functional carcinomas do occur with metastasis to other organs. Investigations. For overactivity of zona fasciculata reticularis, high level of plasma cortisol in the evening measured by plasma fluorogenic corticosteroids by Mattingly method. Cortisol secretion rate. It involves an administration of 14C labeled cortisol and measurement of one of its metabolites in 24 hours. Collection of urine. An assessment of adrenal androgen secretion may be made by measuring the 17 oxosteroid excretion in 24 hours urine sample. In the rare feminizing adrenal tumor in males, the estrogen output may be estimated in urine. Once diagnosis of excess activity of ZPNA fasciculata reticularis is made, some indications of the cause may be obtained by radioimmunoassay of the plasma A.C.T.H. Concentration. Moderately elevated levels are seen in Cushing's disease. Low levels of adrenal edema and strikingly high level of may occur in ectopic A.C.T.H syndrome. Further information may be obtained by the adrenal arteriography. About 70% of overactivity of the zona fasciculata reticularis may be due to Cushing's disease. Pituitary dependent bilateral adrenal hyperplasia. Others, adenoma, carcinoma, and the ectopic A.C.T.H syndrome. Treatment of zona fasciculata reticularis. It is clearly depends upon the cause. The adrenal which is the site of the adenoma or carcinoma should be removed surgically. In ectopic A.C.T.H syndrome, the primary tumor should be removed, but unfortunately it is not possible. Transitory improvement may be achieved by using metyrapone or aminoglutathione to block cortisol synthesis together with appropriate electrolyte replacement with particular reference to potassium. The side effects of adrenalectomy is Nelson's syndrome. It can be prevented by implementation of radioactive yttrium into the pituitary. Achieve somewhat variable result with control of A.C.T.H, secretion and preservation of other functions of the pituitary. Protein beam irradiation may be the treatment of choice in future. Other measures are external irradiation of the pituitary at the time of adrenalectomy. Aldosteronism, overactivity of zona granulosa. It is the hypersecretion of the aldosterone and it may be primary or secondary to some other pathology. Primary aldosteronism, Conn's syndrome, usually associated with an adenoma. The symptoms are weakness due to potassium deficiency, polyuria, polydipsia due to potassium depletion, and impaired renal tubular reabsorption of water. Tetany may be present, sometimes precipitated by alkalosis associated with potassium depletion. The blood pressure is raised, adenoma is present. Treatment. It is treated by removal of the affected adrenal gland. Secondary aldosteronism. It occurs in cirrhosis of liver with ascites in the nephrotic syndrome and less consistently in severe cardiac failure. Potassium depletion may not be detected in plasma. Hypertension is less likely to occur and edema is usual. It is also may occur in patients with unilateral renal ischemia due to renal artery stenosis. Treatment: spironolactone, surgical correction of the arterial defect. And in the next, that's all about the adrenal hyperactivity, and in the next video I will discuss about some other disease.